Hi, so we've got our airway assessment here. So airway assessment is important as it gives an overview for potentially difficult airways in our patients. So we do these assessments because we will look before we leap, so to speak. So to start with, there's basically, you've got your basic airway assessment, which will include your general OPAs, nasos, suction, some supplementary oxygen, just really sort of basics, jaw thrust, even things like that, just to sort of maintain this airway if we can. As we progress from there, it goes into a more difficult airway. So that will be indicated by the patient might have failure to protect their airway or patency, failure to ventilate. There could be issues with the clinical course of this patient, which might present a difficult airway, along with safe transport or safe movement of this patient. So those are well indicated for difficult airway. So we don't actually need much equipment as far as doing a patient assessment goes. With this difficult assessment, we might need something to ramp with. We're definitely going to need our PPE, and everything else is mostly carried in the kit, which is going to relate more to the interventions rather than the assessment themselves. So as I said, we'll just sort of assess the patient next and go from there. Alright, so our basic airway has been completed already, so we're moving into the more advanced, difficult airway assessment now. So usually what we'll see is the old head tilt, chin lift sort of move, where you can find that this actually impedes the airway a little bit with the kinking of the neck. So what we will try and do is actually line up our three axes to their ideal position, so our oral axis, pharyngeal and laryngeal axes. What that will do is put us into a sniffing position, which gives us the best visualization of the patient and also allows for really good airflow. So in order to do this, we need to bring our external audible meatus or middle ear to our sternal notch, best completed through just some sort of ramping technique. So you can use anything around the house or in the car. For our patient here, being able to run to the car and get some blankets. So what we'll do, provided there's no C-spine issues or anything like that, we'd address those, but in this patient, everything's looking fine. So we're going to bring this under the head, and then you might even have to support under the chest a little bit too, with two people often. Just trying to bring these into alignment, particularly that middle ear to the sternal notch, which we've just about done here. So as I've mentioned, that'll give us best visualization for the airway if we are to move into more advanced interventions, and it also allows really good airflow for the patient. So we're in a good position here now, good sniffing position. We now need to assess the patient for difficulties in further interventions, further advanced interventions. So for starters, we'll look at BBM, which is our bones acronym. So firstly, we need to assess for beard or facial hair. So that will impact on our seal. You can see here there's no facial hair, so we're not too worried about that. O is to do with obesity or obstruction. So obesity will do with masses on the lungs or just mass on the chest, which restricts the movement of the air, along with obstruction. So has there been snoring? Is there strata? Is there a foreign body? We need to assess that on the patient and see, okay, what's going on here? Is there an obstruction? Next up is neck mass and neck stiffness. So neck mass goes in with obesity, as we sort of mentioned there, just impacting on the actual airway. And stiffness will really limit us with getting a good sniffing position and being able to sort of move this patient as we need to. So that would be assessed as we would do that. Moving on, we've got E, so expecting, so a pregnant patient. So we're worried about similar sort of thing really, again to obesity, a bit of mass, along with maybe some issues with aspiration or reflux of fluids and things like that. Lastly, we've got S, which is stiff neck. So, sorry, not stiff neck, stiff lungs. So that will actually do with the ventilation of the patient and being able to move oxygen into the lungs and alveoli and issues associated with that. So the next intervention we're going to assess for any difficulties we might come across is our LMA, or laryngeal mask airway. So here we follow the RODS acronym. So firstly we will look at a restricted mouth opening. So is there issues with the actual mouth opening that will impact the insertion of the LMA. Next up we will have is obstruction. So similar to the BVM, is there snoring, is there strata, is there a foreign body? Again, something that will impact on the actual intervention working. D is for distorted airways. So is there trauma? Has there been trauma? Has there been previous surgery? Things along those lines, again, that will impact. And lastly is stiff neck or stiff lungs, much like before, that will limit our either patient positioning or gas exchange. So next we're looking at difficulties with endotracheal intubation. So we follow the LEMON acronym here. So firstly with the L, we'll look externally. So is there facial hair or beard or anything like that that might impact with our intubation? Dentures, any sort of trauma to face, mouth, neck, anything along those lines, and again obesity, which we talked about already. E, we're looking to evaluate the 3-3-2 rule. So it's 3 of the patient's fingers. What we will do is ask them can they fit 3 in their mouth easily? Can you run 3 fingers from the tip of the chin to the hyoid bone? And can they fit 2 fingers from the thyroid cartilage up into the hyoid bone? So that's our 3-3-2 rule. If everything fits there, then we're looking all right for intubation. Next up is our Malin-Patty score. So there's 4 grades there. Grade 1 being our full view of everything, 2 being our soft palate with the uvula, 3 being soft and hard palate, 4 being hard palate only. So that's going to impact on our view and intubation ability. So we've done our Malin-Patty score. We're now moving on to obstruction, which is O. So we talked about obstruction previously, foreign bodies, epiglottitis, things like that. And lastly is our neck and lung stiffness, as it has been in all the previous ones. So surgery, C-spine issues, and everything we talked about. Lastly, in our assessment of this patient for difficulties we might come across in interventions is our cricothyrotomy issues. So we follow the short mnemonic here. So S is surgical intervention. So is there previous scarring along the neck here, which might limit our ability to cut or give us issues, or any other sort of landmarks along those lines. The H stands for hematoma. So are there hematomas around this sort of laryngeal area that will impact? O is to do with obesity. So we've mentioned previously, but that will we'll struggle to find landmarks along this sort of area if they are obese. So that just adds to the difficulty of this intervention. The R stands for radiation. So have they previously received any sort of radiotherapy or anything like that? And lastly, the T is for trauma. So is there trauma to this sort of laryngeal landmark for this patient that will impact our cricothyrotomy attempts? So now we've completed this airway assessment, we're aware of the difficulties we might come across, which will allow us to plan appropriately and execute the appropriate intervention for this patient to improve their airway outcomes, basically. So this is following the look before we leap quote, which is what we're trying to follow here.